Hello and good evening to everyone. Thank you very much for joining us on this epidemiology deep dive. After our conference last week, I realized that there was so much more information that needed to be discussed that I thought to myself that was so important for me to bring some of these epidemiologists back with us so that we can take an international look at what is happening across the world with regards to the pandemic. So, with great pleasure, I'd like to introduce all our guests today, and I'd like everybody to just start off with a quick introduction of themselves. And if you don't mind, Nut, if I use you first as a starting point. Yes, go ahead, Nut.
So I've been an epidemiologist for 35 years, starting in Tübingen, predicting originally correctly that HIV would never spread among Caucasian heterosexuals. I then was teaching epidemiology in Egypt and Lebanon and other places. And then I went to New York and was head of biostatistics, epidemiology, and research design at the Rockefeller University. And now I'm heading a company using genetic data to come up with new treatments for different diseases and prevention strategies for different diseases.
Wonderful. Thank you, Nut. And we have Amitav here as well. If you can unmute your mic, Amitav.
Good evening. I am Dr. Amitabh Banerjee. 27 years I was in the Indian Armed Forces, 20 years as a field epidemiologist. And 5 years I was heading the mobile epidemic team of the armed forces. I investigated outbreaks of communicable disease, respiratory disease, waterborne disease, malaria. For the past 17 years, I am leading a more quiet life as an academician. I am professor and head of community medicine and epidemiology in a medical school in Pune, India. And we have been associated with the COVID work given to us by the district authorities. And that's all we are doing, field surveys, sero surveys, contact tracing. And I'm glad to be here again.
Wonderful. Thank you, Amitav. And Shankara?
Hi, Philip. Hi, everyone. I'm Dr. Shankara Chechi. I'm a natural science biologist and a general practitioner in South Africa on the front line seeing COVID patients. I've had a hands-on experience with COVID through this pandemic.
Wonderful, wonderful, wonderful to have everybody here today. And what we're going to be probably trying to do is to quickly get an overview as to what's happening across the world. And Amitav, when we had done our conference, we couldn't go into enough detail with the presentations, both from yourself and Nut. So we're going to try and see if we can go through it in a little more detail. So we'll start off with you, Amitav, and I'll bring up your presentation so that we can focus a little bit on it here. Let me just make sure I have got everything correct in the right place at the start, and I will just bring it up for you here now. Great. Is that about the right place to start?
We can start with the next slide. Just given an overview of the picture around the globe, there are marked differences in the cases, and particularly I have tried to compare the mortality rates across the three continents and different countries in the three continents, and there is no uniform pattern. And in the subsequent slides, I have tried to correlate it with the obesity patterns and the age profile. And there is a marked difference depending on the obesity and age profile, and obesity is coming up as a major risk factor, as we will see in the subsequent slide. Another thing I have seen is countries which went for restrictive measures like Sweden and Japan, they did not fare badly compared to those countries which had very strong restrictive measures. In fact, Sweden now is very comfortably placed as far as cases and mortality is concerned among the European countries, and Japan in the Asian countries, we did not have a lockdown, is also very comfortably placed. Of course, Japan has an advantage of a low obesity. So that is a very much modifying factor. And there are other trends which is quite disturbing, that we thought once we get the vaccine, we will get a grip on the pandemic. But country-wise data, the ecological data, that the different countries, particularly the Asian countries, I have got data, After the rollout of the vaccine, because particularly Sri Lanka, I was following Sri Lanka because it is neighboring to India. And before the vaccine rollout, Sri Lanka was very comfortably placed. It was hardly having one-tenth of the caseload and the death rate compared to India. But after the vaccine rollout, the cases also climbed sharply and the death rate also climbed sharply. We will see the trend. This data from the public domain. And can I have the next slide, the three continent slide?
Yes.
This one. This, if you see the red are the American and European continents, the green are the Asian countries, and the blue are the African countries. And the first column is the age, median age. So the median age is higher in the northern hemisphere, around 40, except for Brazil. Brazil, the median age is 30. And Brazil is a very interesting example with a lower median age. It has got a very high obesity. Second column is the obesity. These two are coming out as major risk factors. If you see this is overweight. Overweight is BMI more than 25. That is the 60% is the most of the European countries, and in the 20s is the Asian countries, and similarly African countries are 20, except for South Africa and Egypt. And South Africa is having the higher rates in the African continent, and to some extent Egypt. So there are many factors. Probably the urbanization, South Africa may be more urbanized than Egypt. So that is one factor. Other factor is the death. The third column is the death per million. If you see, there is a very distinct, the European and American countries are having death per million in the 4 digits, while the Asian countries are having in 3 digits, and the African countries are having in 2 digits. And if you see the last two columns are the vaccination coverage. So consistently, the vaccination coverage is higher in the northern hemisphere, but still, the second last column is the death in the last 7 days. This is the third last. Third last column is the 7-day average mortality. If you see, Sweden is doing very well among the European countries. I mean, they did not have restrictive measures, but other European countries, in spite of higher vaccination, they are having the higher 7-day mortality. Compared to the Asian countries and the African countries with hardly any vaccination coverage, they are very comfortably placed even without adequate vaccination coverage. So the question is that this COVID is driven by other factors, combination of factors like obesity. Obesity per se may be a risk factor, and obesity may be a surrogate marker for other comorbidities like diabetes and hypertension and coronary artery disease. And age also is also a marker of comorbidities. So these are perhaps more strong predictors of the mortality and severe disease. Then it can be prevented by vaccine. So this is what I think. This is really a pandemic of comorbidities, and this virus may be just the last straw on the camel's back. That if we are neglecting the comorbidities and we are only concentrating on one solution, that is vaccine, we may not make much headway. Next slide, we can just have a look at the trend after the vaccination rollout in some countries. This is also an important slide for policy. Like 0 to 19 years, this is the meta-analysis of a number of studies done by John Ionitz. Ionitz is the second author. And the survival after COVID infection 0 to 19 years is 99.9973. And up to 20 to 29 years also 99.986. So this and right up to 50 years of age is 99.7, and elderly 60 years plus it is 99. I am 60 plus, I am nearing 70. So at least at this age, anything can kill me with more probability than COVID. I mean, I was just seeing to get things in perspective, particularly in Asian and African countries. We have got so many communicable diseases, tropical diseases, all have got mortality 5%, 10%, and we are comfortable with it. But why we are getting obsessed with a survival rate of even at the 60 years of age with 99% survival rate? It somehow, I mean, when you are planning public health, you have to weigh epidemiology is one aspect, then other aspect is the public health economics. Next slide, I think there's a Sri Lankan paradox we can go through. When this is the one which is, I was saying, up till the vaccine rollout, that was somewhere in the March, April. The vaccine rollout, before that, the Sri Lankan cases were not very high. And immediately after the vaccine rollout, these are the surge of cases. And PV is partial vaccination, FV is full vaccination. And of course, after the surge, it comes down like any pandemic because the susceptibles get exhausted. So that's a natural phenomena, but vaccination causes a spurt, and this type of phenomena is evident in number of countries, Indonesia, even Singapore, Israel also. Next slide gives the mortality also in Sri Lanka. Next slide, please. This is also a case for concern, because I'm not much concerned about the cases, because cases, most of them are mild in nature, but the deaths have also increased. And there's a recent studies published in one of the journals, European Journal of Epidemiology, which 68 countries, they have found that there is no correlation between vaccination coverage and the in last 7-day incidence. And also in I think in the America also they have done more than almost 3,000 counties, they found no correlation with the vaccination coverage and the trend in cases. So this is something which is quite disturbing, because we have to rethink before rolling out mass whether we are getting the really benefit. Thank you.
That's quite fascinating, Amitav. And just before we move on to talking a little bit about what Nut is seeing in North America, Shankara, I'll just ask you clinically, any thoughts about what you're seeing there? Does that fit any pattern? I mean, that's quite remarkable statistics.
Yeah, that's exactly what I'm seeing, Philip. It is age stratified. And of course, the obesity plays a huge part in this. I think diabetes would consider one of the biggest risk factors in the illness itself. But from the perspective of treating it, I would say that the morbidity and mortality in the illness is easy to curb with early treatment. Though you find, if you look at the way patients progress in this illness and the difficulty with which the recovery takes place, it is definitely dependent on the comorbidities itself. And as Amitabh's been saying, yes, as you get older and you have more comorbidities, you generally take a little longer to recover from illnesses. And that's generally the trend that I've been seeing.
Mm-hmm. And we're going to come on to your experience, Nut, or what you have been seeing with regards to North America. So probably maybe what we'll do, we'll look at that, and then we'll have a general discussion about some of these patterns that seem to be emerging across the world. So do you want me to bring up your slides, Nut?
Yep, please do.
Sorry, let me just share this here. Okay.
Okay, let's start. First, I would like to mention that epidemics follow certain rules. And one thing, the red curve that you hear is the curve of infections. Every epidemic starts, peaks, and then goes down by itself. So it's not that the increase is due to all of the unvaccinated and the decline is due to all of the politicians. Both of these trends are natural to every epidemic. An epidemic where you don't do anything always looks like this. It goes up and goes down, and it's pretty symmetric.
Mm-hmm. You want me to move on to the slide? Next slide?
Go ahead. Okay, so now here we see hospitalization in the United States, and we saw that there is a nice symmetric curve earlier this year. Well, the current curve deviates a bit, so it's not quite clear what is happening right now, why the curve is flattening so much at the very end. But something that is very striking here is that the risk of dying is high among the elderly, and very on the top in blue, and at the bottom in yellow, very low among young people. So it remains a disease of the elderly and not a disease of the young. Go ahead. Mm-hmm. So this is the death during the whole epidemic in the United States. And you see it was a bit skewed, but otherwise quite normal, a curve early 2020 on the left side, at a time where nobody was vaccinated. And now, recently, we have a curve on the right side, where almost everybody of the elderly is vaccinated, and for reasons that are not easy to understand from what the politicians are telling us, we now have more deaths. The curve is wider, much wider than it was earlier. We have more deaths, even though the vast majority of people who are at risk are vaccinated. And if 95% of people are vaccinated, even a disease like measles could not spread anymore. This is herd immunity. Go ahead. So now if we look into other countries, we see very similar, other European and Northern countries, we see very similar trends. There was an early peak last year in March and April. There was another peak in January. And then we have now a peak that may be at the top, but what we see in several countries, including the United Kingdom, at the bottom right, we see that the number of deaths seems to go up again. And that is something that you would not see with a simple epidemic. So it may be that new strains are coming. We don't know yet, but it is a very surprising fact that we don't have that typical bell-shaped curve, or bell-shaped curve, that we have something that is wider and goes on, and we don't know why yet. Mm-hmm. But it doesn't seem to depend very much on vaccination.
This is it's difficult to, how do I start with this then? We are at a point here now in the pandemic where we should see success. Is that about right? Is there, well, I'm trying to understand, is have we given it enough time in order for us to say that we have reached a point of success with regards to our strategy with vaccination?
Well, whenever we do lockdowns or other forms of mitigation, we are flattening the curve. That was the original argument last year why lockdowns started. The purpose was to flatten the curve. And if we are flattening the curve, it takes more time.
Mm-hmm. And so, in effect, then, because you were one of the advocates, not that we shouldn't have locked down, but we should have left the...
We should have at least have reopened as it was promised by our politicians after 3 or 4 weeks, when we had the data showing that the hospital system would not be overwhelmed, at least not in the United States and in Europe.
All right. Here's a question that I want to put to Amitav now. When the Delta variant kicked in, and this was in about January, are we just seeing a new variant that has evaded the technology of the initial vaccines, and that an updated vaccine is likely to do better? Would that be an unreasonable perspective, Amitav?
Delta variant in India was detected somewhere in October last year. And then the curve came down. January, February, it was almost touching the baseline, and Delta variant had just kicked in. And then March, the vaccination was rolled out. And just after the vaccination was rolled out in March, there was a huge surge, 4 times than the first wave in India, which took everyone unawares. And that was due to the Delta variant. And I was just wondering whether Delta variant was always there before vaccination, but perhaps the previous variant must have kept it subdued, and vaccination was against the earlier variant, and that Delta variant perhaps got a opportunity to thrive and multiply and And subsequent variants are more contagious. They need not be more lethal. And then there was a panic actually because of the huge surge. And the fear factor, the population fear factor was very high throughout the pandemic. And
I
I
would
was
like
just,
to
I
add
think,
something, and that is
yeah,
that
Go ahead, Nat.
we
Yeah.
have not only one Delta variant, we have more than 25.
yeah.
So we
What
have
is
a
that?
huge variety of Delta variants. And right now, what is worldwide spreading is the AY4 variant of Delta, and others are likely to come soon.
Hmm.
So,
And
And that may actually be that we have all these different Delta variants, maybe the reason that the recent curves look more flat than the previous curves.
And so then it would beg the question then that if we just updated the vaccines, which would include the Delta variant, should we not see more success to control it? And that would almost support the booster thinking in terms of using booster vaccines.
Well,
but
what
these
we
boosters are,
know already from influenza is that these viruses vary a lot. Now, influenza varies only randomly, and even that random variation makes it very difficult to come up with a vaccine at the time where a new virus is spreading. The COVID variants haven't randomly varied. The Delta is the first where the selection was influenced by the presence of vaccines, and whatever is the next virus that will spread will have been evolved to specifically be resistant against the vaccines that we have. So we would need an entirely new vaccine that works against the new strains. And to develop that will probably take more time than the new variant needs to spread.
I just pause. And Shankara, from your clinical experience, because you've seen both the Delta and the South African variant, and it changed the clinical presentation. Any thoughts on what you're hearing?
Absolutely correct, Philip. 2 points. From the South African variant, it was not such a contagious variant, but it was a more lethal variant. We had a far more severe illness in the inflammatory phase of the illness. So we saw a lot more deaths. The Delta variant was a far more contagious variant, but a milder variant. And from a clinical picture, was a lot more easy to manage. Also, coming back to the vaccinations and how they seem to be triggering the variants. In South Africa, we had a vaccine rollout that started in one province and then moved to 2 other provinces. Now, it started in a province called Gauteng, and then we moved on to vaccinating in the Western Cape. And then the third province to be vaccinated was KwaZulu-Natal. And what we found was the surge in cases in the Delta variant followed that exact pattern. Gauteng was the first after vaccination to have a surge in cases. Then the Western Cape had a surge in cases. And then KwaZulu-Natal had a surge in cases. So yes, I've also noticed that the vaccination seemed to be followed by an increase in cases, which might be that we're selecting for variants that can evade the vaccine and so spread through the community a little more easily.
Hmm. This is probably a good time, Amitav, to see what's happening in some of the other countries across the world. So I'm going to bring up your slides again in a second, just to see that global pattern that seems to be occurring. This is in Malaysia.
Malaysia, same picture. Before the vaccine rollout, the cases had come down, and after the vaccine rollout, again there is a surge. After the surge, it comes down because susceptibles are exhausted, whether by natural or vaccine induced. And similarly, the deaths in Malaysia also. If you see the next slide, these are the cases. Next slide gives you the deaths in Malaysia. Again, there is a surge after the vaccine rollout because large number of cases. So they were doing pretty comfortable before the vaccine rollout. So this mass vaccination, one has to pause and think so much resources and whether to go for selective vaccination or for mass vaccination, because like if the strain keep changing, you have to manufacture very fast, as Nut said, to keep up with the pace. You will be always one step behind. The vaccine will be one step behind. So if you have a small target population to vaccinate, you can update it faster. And it's the money also, and the resources, and the panic, and so many things. Next slide again, I think it's Indonesia. Next slide is Vietnam. Vietnam, similar picture, that they were always at the baseline, but after the vaccine, I don't know countries which didn't have cases why they went for mass vaccination, and that some beats me. And the deaths also, the next slide would be the deaths in Vietnam. It's after the vaccine rollout. I mean, this is again whatever little surge. And similarly, of course, Singapore was doing very well. Now, next slide is, I think, Singapore, Indonesia. Indonesia, again, the same picture. It had come down after the vaccine rollout. Same in India. This is almost mimicking the Indian picture. And this is after the vaccine rollout. And again, deaths also, same pattern. So this is the death pattern, same pattern. Exactly, it's almost mimicking India. After the vaccine rollout, there is a surge. Then again, I think next slide is Singapore. United Kingdom. Again, actually, in United Kingdom, cases had come down, and I think July is not a time to have the surge. It comes in autumn and winter. So after the vaccination, there is a surge, and as on today, uh, I think last 25 hours, UK had 40,000 cases. India had just 20,000. Double. The population of UK is 20 times less than India. So this, of course, you would know what's happening in UK better, Philip.
Mm-hmm.
Next is, I think, India. This is the deaths. Of course, deaths in United Kingdom had come down in the second wave. This is Singapore, because United Kingdom deaths, because in Western countries it follows a pattern. No? After one wave where the elderly die, the subsequent wave they are less vulnerable people. So deaths is always lower in the subsequent wave compared to the high death wave. So that is one phenomena. This is Singapore data. Again, it had touched baseline, and after the vaccination, there is a surge. And death. Next slide would be deaths in Singapore. I think Singapore is a very small country, so it's hardly. This is also deaths. So these are small countries are not able to cope up. 70-80% vaccination coverage, and I am really concerned. A country of India size, 136 crores, how much investment it is spending, and whether it will get the returns. The question is not investment, whether it will get the returns, or it is going to. I mean, it's something which is quite. Now, I think next slide is India. I think India again. Next slide is India. This is United States. Okay, United States again same after the vaccination. I think Kunut will be able to tell better. We can go to the next slide, next slide, and see what is the Indian pattern. It is United States. This is India. All it came down to baseline, and after the vaccine rollout, it came very fast up and very fast down. The faster is the Delta variant. It spreads, and now, as on today, almost 80% people have seropositivity. Before the vaccine rollout in June, they had a survey. All India, they found 70% had already developed antibodies, where the vaccination coverage was just 5%. So we have already developed natural immunity from the Delta variant as well as from the previous variants. Actually, field practice area in the first wave, after the first wave ended in October, we did a survey. We found 35% of people are having antibodies. And after the second wave in June, we did a survey. We found 80% are having antibodies. And another thing we did is we followed up about more than 1,000 people from the first wave to see how many got reinfected in the second wave. Less than 1% got reinfected. So the natural infection from the first wave gives protection against the Delta variant also, because natural infection, the whole virus is, the immune system is exposed to the whole virus. So that way, natural infection is better than the vaccine long term.
So the question is, and one of the arguments for going for vaccination was that we don't know the duration of natural immunity. So will we then see, as Nutt had pointed out, that if we have these new variants coming, are we then going to see another surge of COVID if we don't vaccinate? Any thoughts on that, Nutt?
This has nothing to do with the duration of the effect of the vaccine. This is just when a new virus arrives that is resistant to the existing vaccines, then we have a new epidemic that follows the rules for new epidemics, and there will be little, if any, effect from the old vaccines.
Any thoughts on what you've just seen there, Shankara?
Yeah, I think Nat is correct, Philip. The vaccine, if it's not going to provide us appropriate immunity for an emergent strain, that emergent strain will follow the natural progression of a pandemic, or the natural spread of infection. So we're going to see it spread through the community, irrespective of vaccination coverage. And I think that's the reason the vaccines don't seem to be affecting the spread or the curve compared to the unvaccinated or the natural spread of infection.
So is this just a situation where you just let it go? Is that what you're suggesting, that this is the point where
No.
we no longer? No?
We should do something, but we should do something that is appropriate for this time of epidemic, or for this type of epidemic. And we have already seen what the major risk factors are. There are obesity, type 2 diabetes, atherosclerosis, and other cardiometabolic conditions. Without these cardiometabolic conditions, the risk of dying is pretty low and extremely low in the young people.
Mm-hmm. And so I would take it from some of those thoughts that what would therefore, from an epidemiological point of view, are we along the correct line to say vaccinate children? Any thoughts on that, Amitav?
Children, they are at very low risk, 99.99 survival. So certainly the vaccination is not indicated in children. Uh, Neither do they transmit, neither do they suffer. And I don't think there is any logic, because there are so many other childhood diseases which require vaccination, like measles, diphtheria, whooping cough. Because in a poor country like India, because of this too much focus on COVID immunization, most of the resources got diverted, and the measles vaccination and other real effective vaccination will suffer, and we will have more child deaths from measles and other neglected infections, where we really have a good vaccine. And this vaccine we don't have, which is not showing efficacy even in adults. So why we want to invest money? But it is not only about efficacy, it is also public health, is about economics also. So there is no economical, scientific, or whatever reasons to go for mass vaccination of children. We may consider if suppose some child with comorbidity, that also requires more research.
And Shankara, any thoughts?
Exactly, Philip. I agree with Amitabh. In all the patients I've seen, I haven't had a child get critically ill. They don't go into the second phase of this illness because of their poorly developed immune systems. So I don't see the reason to vaccinate children. They do not spread it as much as we suspected. They're not at high risk. I think we'd be better advised to focus on the child health, metabolic disorders, obesity, that kind of thing. And we'd get better benefit out of that. Vaccinating children, remember that we don't see much mortality there, and we're unaware of the safety of vaccines. So putting the mass of children at risk of adverse events is nonsensical. They're not at risk of the illness itself, and they will contribute to the pool of herd immunity in the long run. So they should be allowed to get this virus, get over it, and contribute to that pool of herd immunity.
But I can tell you that many parents are anxious about some of the things that they have seen in the news. There are children being hospitalized early in the pandemic with the Delta variant. There were more children being hospitalized. When you see those kinds of stories, parents will naturally get anxious about it, and they will be concerned. Why would you want your child to get COVID if they can be vaccinated and protected? Not, you seem to be wanting to say something on that.
But Philip, you have seen the data. I showed it. The hospitalization data, the yellow curve of the children everybody below the age of 18, was so low that you couldn't even see it. It is not an epidemic of children. It continues to be an epidemic of the elderly, but many of the elderly, of the highest risk people, have already died, and so they cannot die again. And that means that even the small number of children is now a larger proportion of the people who die.
Yeah, and so here's an interesting question that Aditi has asked: should therefore schools reopen in this situation across the world where we still have virus spreading? Is that the appropriate thing to do? Are we supposed to now just accept that children should get COVID-19?
Well,
Philip,
children not
here,
only, sorry, go ahead.
sorry. No, you go ahead, Nat.
Not only don't get it, they also don't spread it to the high-risk population. We don't have homogeneous mixing, as the term is called. It is not that the majority of the elderly people every day plays somewhere in a playground with small children. This does not, the elderly and the children live relatively separated lives. And so if we have 95% of the elderly being immunized or being immune, that means that even if one person should become infected, that elderly person is not spreading the disease to anybody else. So even now that if somebody gets infected in a nursing home, nobody else will get infected because of the high level of herd immunity that we have among the elderly.
Mm-hmm. And here's a point that I was mentioning, and AK has it. How can you, as practitioners, even advocate that children get this disease? Is that appropriate? Amit, have any thoughts about that?
It is no question of prevention. It comes naturally. In Indian survey, 70% adults were having the antibodies and 65% children were having the antibodies. So it did not prevent. The closure of school did not prevent. And we are exposed to so many infections, children, and they develop immunity. I mean, it matures the immune system. I mean, it's something which you can't prevent. You can't say how can you allow flood to come. Flood comes, pandemic comes, and we have to see which are the vulnerable group and protect them. Children are not the vulnerable group. We have traffic accidents daily. 500 children die of traffic accidents in India. We have not closed the automobiles. So in deaths, hardly any child dies of it. So if the common man, the parents should see the relative mortality, which are much more. We are having dengue in our country where children are dying every day. Japanese encephalitis in our country, the neglected tropical diseases, and we just can't afford to go for where no child is dying of COVID. I have got the comparative data.
Here's a good question. One of the things that's in the news is the unvaccinated being in hospital, and this is a pandemic of the unvaccinated. It's difficult to know without data, but does anybody get that feeling from the epidemiology? Is that what we're seeing across the world?
Philip, I don't think that's correct. We've 3 months into our vaccine campaign here in South Africa, and I'm seeing daily breakthrough cases in fully vaccinated patients. I think there's a few things that I think are vitally important to understand. I think that the vaccines are conferring the safety against severe illness and death, not through any immunologic benefit in preventing infection or transmission. We know that it is an immune-mediated reaction to spike protein that tends to cause the mortality and morbidity. And so I think that the vaccines, in exposing a population to spike protein, are conferring on them a limited measure of tolerance. And so immediately after the vaccines, you see that those that get COVID tend not to have severe illness or deaths. But as that tolerance wanes, you find that those that get infected are no different from those that are unvaccinated.
And so
I
here's
think the
another
whole
question. Yes.
focus,
Go ahead, Nut. Go ahead.
the
I'll come
whole
to that question.
focus on
I'll ask you to
exclusively
speak a little louder
relying
for me, Nut.
on,
Can you come a little closer to your microphone?
okay,
Yeah.
the whole focus on relying exclusively on vaccines, I think, is misguided. And if we are looking into the epidemiology, if we are looking in particular at the comorbidities, I think we have a much better way of dealing with the problems in addition to the vaccines that may be useful for some populations. And so if you, I had prepared the slides, so if you want to show those, then I could make a suggestion where I think we should go in focusing on the risk factors of having a severe disease other than being vaccinated. So we have seen there is no epidemiological evidence that the pre-alpha vaccines are as effective as people were hoping against the Delta and other viruses. So the virus that will be spreading in the future will be even more resistant than the Delta. So unless we come up with new vaccines, the effectiveness of the vaccines will go down. So we should use social distancing, but only where it is really necessary. That is in nursing homes where we don't have high levels of vaccination. And then the elderly with comorbidities should be supported to self-isolate. But that doesn't mean that everybody else should do the same thing, because everybody else, if everybody does the same thing, the virus spreads more slowly, but as much among the vulnerable as among everybody else. And in the end, more of the vulnerable will die. So we should have vaccination in some groups. For instance, healthcare workers should be vaccinated because we want to reduce any risk for the immune compromised people that they're interacting with. And people with comorbidities, and that includes actually children with type 1 diabetes, they should be offered vaccination because this is where vaccination could have the most impact. Otherwise, I think we should focus on reducing comorbidities. We know that, for instance, that intermittent fasting is a strategy to help with reducing many of the comorbidities, but not everybody can adhere to such a regimen. And so intermittent fasting mimetics nutritional interventions that give the benefit of fasting, even to those who don't, would be something that could be extremely helpful.
Excellent. And any extra thoughts that you would add to that, Shankar, from a clinical perspective?
I think Nat is absolutely right. Philip, from a public health strategy, the aim in this pandemic would have been to get to herd immunity, natural herd immunity, as quickly as possible. So those that were least at risk will be the ones that are going to form that pool of natural immunity and shouldn't be restricted. Any restriction will flatten the curve, but prolong the pandemic itself. So you're prolonging the inevitable. And we're going to see that in countries like Australia and New Zealand, where they had very strict lockdowns with no cases. So I think that the public health measures of isolation, social distancing, vaccination should be targeted at those that are vulnerable in society to protect them from mortality and morbidity. The rest that are not really at risk should be allowed to be out there and free, to allow the free spread of the virus so that we can get to herd immunity quickly enough before we end up with mutations and many variants and all that kind of thing. So I think Nat is absolutely right that the measures targeting the prevention of spread should be limited to those at risk.
This is a good. Go ahead, Nat.
A short comment, and that is vaccines have a value in shortening the time it takes to get to herd immunity. because people get immune earlier than they otherwise would if they are vaccinated against the current virus. But the mitigation efforts, lockdown and social distancing and masking, they do the opposite. They are flattening the curve, prolonging the time that we need to herd immunity. So if we do both at the same time, vaccination and mitigation, what we do is as effective as sitting in a car and hitting the brake and the gas at the same time.
Mhm. Yes, yes. Well made, not well made, not. Amitav, I'm going to bring up your slide again from what you had seen from a countrywide observation with regards to COVID-19 to try and almost focus our minds in onto what is the important thing to take from the pandemic here.
Age, of course, because with age you have comorbidities and overweight. Japan stands out. Japan has the oldest age compared to even Western Hemisphere, but it is obesity, overweight is just 27% compared to 60% overweight in the Western countries. Similarly, Brazil is a younger population, but it has got a overweight almost 60%, so it is having a higher impact. And higher vaccination coverage, as we have seen, is not associated with the trends in mortality as well as a. And the combined effect of host factors, which are more important, like age, obesity, and this is another thing which has come up as cross infection with other coronaviruses, particularly in crowded or highly dense countries like Bangladesh, Pakistan, India. The populations are very crowded. In fact, the lockdown had the opposite effect of they were crowded in small houses, in slums, in tenements, and that's why probably India has one of the highest level of seropositivity in the world, almost touching 80% as on today. So these all can have a more strong determinant of the COVID trend than vaccination per se. And now the measures taken like lockdown and restrictions, they have increased the obesity. I just saw the paper today in JAMA that the pediatric obesity has increased during lockdown, and you are making them more susceptible. Similarly, anxiety disorders is also coming up as a major risk factor after obesity to the severity of COVID infections and deaths. The second is the anxiety related disorders, which may lead to overeating, overdrinking, heavy smoking. And these are the things which we have increased by our restrictive measures, almost amateurish measures. As we do lockdown, then we have vaccine, and then everything will stop. This was just like a timeline we made, which wasn't a very well balanced or just a single way of thinking, tunnel vision. Whereas the other factors like obesity, and other comorbidities, other health services were suspended. People were afraid to go to hospital for their diabetes checkup. People were afraid to go for their cancer treatment. So all this have perhaps increased the impact of COVID will also increase. And particularly in developing countries like India, child malnutrition has increased because of loss of employment.
Mhm.
So
So it looks as though, you see, hindsight is always 2020, and it's easy to look back and say we should have done this better. Sometimes, say for instance, with regards to lockdown, I can say that I was one of those people who thought we should have locked down because at the time when we were early in the pandemic, we needed to protect the vulnerable. We didn't understand the disease. That was the first wave. The second wave, you could argue that we had learned a bit more, but just the same, the anxiety of the public would have driven governments to need to lock down again. Here we are now. Are we on the brink of a third or fourth wave? And I still
Yes.
don't know. Yes, and not what are you going to say to a government? How is a public health organization going to
Okay.
allow
I would
this?
like you to go to the slide 11.
Hold on one
It's the
second.
diagram,
I'll get
because
it
it
up.
shows the two things that we can do with today's nutritional interventions to achieve what the vaccines were supposed to achieve, but don't really. And So the one thing is the next one. So this was my contribution in 2020 that I published end of March, where I was arguing against lockdowns. No, the one before that, this one. So in yellow, we have all the comorbidities, and we know that if we are reducing phospholipids, a particular fat from eggs, from egg yolks in serum, we are reducing these comorbidities. But there is another component in the etiology that is very important for the epidemiology, and that is to be replicated. The virus encircled in red here needs to enter a cell to be replicated. And the virus cannot do that by itself. The virus needs to be actively endocytosed by a cell and then replicated by the cell. And what we found out through genetics and then through other methods, we can reduce endocytosis or reducing phospholipids in serum also reduces endocytosis. And if we are reducing the uptake of viruses by only 10% for each of the 7-hour replication cycles, we have reduced the number of cells that get infected during the 5-day incubation period by 80%. And this is achieving the same thing that we want to achieve with vaccines, and that is reducing the severity of the disease on the very right side, but also on the very right side in red. We are reducing the ability of people to spread, because if they make fewer viruses, they have fewer viruses to spread. So we have a strategy, and we know how to do it to reduce both the spread and the severity of the disease. And if we are reducing both of those, we have turned COVID into a minor annoyance rather than in a threat to the whole society.
It brings a question that is a very controversial question, and I was involved in this discussion recently about ivermectin. So many countries are using ivermectin, and I think specifically about a presentation that I saw from Honduras, where they use it as a national strategy, and they had found it made a huge difference. Could something like ivermectin be having that kind of impact with regards to spread of disease? Any thoughts? Not? You want to go with that first?
No, it could not. First, it's a treatment. It's not a preventive intervention. Ivermectin has been used for twice within a 2-week period to first kill the first generation, the current generation of parasites, and 2 weeks later, the next generation. It's very effective. And if you use it like that, it will help a lot. But we have no good evidence that it's working against viruses, which are very different from parasites, small animals that live very proactively. Viruses don't live. So the whole mechanism of action on which ivermectin is based as an anti-parasite medication has no impact on viruses. And how that is supposed to work on viruses is very unclear. And we have recently, a paper was published in Lancet, I think it was, where people, a whole group of people have reanalyzed the quality of previous studies and found that these studies were mostly of very low quality, and 2 of them are currently being retracted because the criticism was so severe. So it is, I don't think that we don't have good medication against any virus disease, with the only exception of hepatitis C. And it would be very surprising if suddenly something would be found against this very dangerous coronavirus that was never found against any other virus. Just remember, if you have a flu and you treat the flu, it takes 7 days. If you don't treat it, it takes a week.
Yes, and so in terms of I'll take the ivermectin point a little further. And Amitav, one of the things, and we have discussed this before, ivermectin. When we look at what happened, say for instance in India, and somebody had raised the question about Uttar Pradesh, the difference between the districts and the use of the ivermectin. Can we completely discount it, Amitav? Any thoughts from a real world perspective?
These are actually correlational studies, so it is very difficult to really establish. Like Uttar Pradesh is a state which is a very high population density, and the people are more rowdy they compared to the southern states, particularly states like Kerala and Tamil Nadu. So Uttar Pradesh, perhaps they might have reached a herd immunity also faster by natural infection. I have got this hunch. And of course, ivermectin, otherwise, as I said last time also, it is freely used all over India off the counter also. It is easily available. And my basic, as I said earlier also, with a disease with the outcome is so rare, death is so rare even in the elderly, and death is more with the other factors like comorbidities. So it will be very difficult to tease out whether it is ivermectin, whether it is remdesivir, perhaps whether it is vaccine also. So I think overall, general good health is the best protection, and I think none of the intervention can stand RCT because
Mm,
of the low outcome.
yeah. Shankara, any thoughts?
Philip, with what I've seen with ivermectin, the trials that were done showed the most benefit in prophylaxis, decreasing to early treatment and the least in late treatment. From the clinical perspective, I've always used ivermectin for its immunomodulatory benefit rather than any antiviral activity. I think the immunomodulatory benefit is well documented. And so I use it generally in the late stage when the immune mediation is more important. And we have a host of medications that can perform that same task. So it can be a replacement for steroids, but of course there's dose issues, so effective dose, and of course the absorption, so that you might have to start it a little earlier to get a benefit from it. But as far as widespread use of ivermectin, here in South Africa, a lot of people in this third wave have been accessing ivermectin and using it supposedly prophylactically. But I've seen a lot of patients present to me that have been using ivermectin that do still get coronavirus illness and still do progress into the pulmonary phase of the illness and require other intervention to actually treat it. So I think we need to be a bit cautious about pushing any specific treatment, but more understanding what's actually happening in front of us.
Excellent points. All well balanced discussion. We're coming to our end point now, and I wanted everybody to think about what they would advise from and using your epidemiological evidence, or Shankar, your clinical experience. If you were speaking to one of the leading organizations in your country, or say the World Health Organization, what would you be saying to them? And I'll probably start off with Nut on that, and then I'll ask Amitav and then Shankara.
We have already type of supplement that has been approved in Europe for the prevention. I formulate a bit more lax here, for the prevention of type 2 diabetes, in the United States for the prevention of cardiovascular diseases, and is well known to reduce obesity. It's alphacyclodextrin that is actually grass. You can buy it as a food supplement. It is contained in many of the food that people are already taking. And so some people may already have the benefit from it if they are taking it with a milk product. And I don't have the time now to go into the details. But this type of intervention that is known to be extremely safe and to reduce comorbidities with clinical benefits shown in many studies, and nobody is really doubting it. And the other is with the high potential of also reducing the replication of viruses. Using nutritional strategies is something that at least should be discussed. We shouldn't focus exclusively on vaccines and antibodies. We should also include strategies that can more easily and more widely spread across the world, even if pharmaceutical companies are not making that much money with it.
Right. And Amitav, your thoughts?
I think as far as India is concerned, it has already reached herd immunity by natural infection, and with our competing other tropical diseases, the COVID should be taken as any other disease in its stride. It should not too much resources not warranted, particularly mass vaccination. Though even one dose has been given, that one dose is as good as two doses because majority of the population already have got natural infection. So, but anyway, they are going ahead with the whole world, whatever the protocol, two doses. But I don't think it is going to be endemic disease like any other viral disease or the seasonal flu. So, in the long run, I don't see any special measures would be required for COVID.
Mm-hmm. And Shankara?
I think Amitabh and Nata are exactly on point. All the public health measures so far have shown no benefit. The lockdowns haven't done what they should, neither have the vaccinations. If I had to give some advice, I would say there's a wide body of population that have developed herd immunity. Let's get them to take off their masks and go back to normal life. Let's test immunity in our society. Let's target vaccinations or isolation measures to those that are the most vulnerable. And by doing that, we would improve the general health of our population. The sunlight and ventilation are the two best ways of curbing the spread of this virus. So having people out there exercising, socializing, will decrease obesity, the first main risk factor. By unmasking people and getting our economies up and running, you'll take away all the fear around the pandemic and take away the second biggest risk factor in this pandemic. And without a shadow of doubt, this is going to become endemic. So we should at least stop chasing the numbers in cases. Reinfections are generally a God-given booster shot. We don't need to go around counting every infection that we have. That just stokes the fear. So I think a complete rethink of the public health strategy. We go back to pre-pandemic, what we were doing pre-pandemic, and be very targeted in the interventions that we've pushed forward so far.
Excellent, excellent, wonderful. And I think that's quite tremendous. I'm glad I got a chance to go through those slides from both Nut and from Amitav. I thought that those were really showing clearly that across the world, it does seem that there's a consistent pattern and one that we should not ignore for the future. So thank you everyone again for listening to us. I thank my wonderful guests for being here with us, and we look forward to having another conversation in the near future. I'll ask you both all to hold on for me while we do this outro. Thank you all for listening.
Thank you, Philip.
Thank you.